Medical Service Company prides itself on being able to meet the needs of all patients requiring oxygen therapy. We're proud to offer a portable oxygen concentrator as our standard mode of portability for patients requiring oxygen for ambulation. Providing a portable oxygen concentrator helps patients maintain an active lifestyle. Another great benefit is the role it can play in expediting a hospital discharge. MSC works with several health systems to assist in discharging patients from hospital to home in an efficient manner. For patients who have received their oxygen from another provider but would like to obtain a POC, MSC may be able to assist with transferring their services to us. At Medical Service Company, it's our goal to help every patient maintain an active lifestyle without their use of oxygen therapy compromising that freedom. For more information regarding our oxygen and portable oxygen equipment and services, visit medicalserviceco.com.
I hope you are enjoying this day of healthcare education. This brings us to our final speaker for this afternoon's respiratory track. This lecture will be presented by Dr. Keith Robinson, who will be speaking about the COVID-19 pandemic in the clinical environment and the implications for long-term and short-term oxygen therapy. Dr. Robinson currently serves as a medical director at Syneos Health, an end-to-end, fully integrated biopharmaceutical solutions company. Previously, Dr. Robinson served as an associate medical director at IQVIA and medical director for Fusion Health and Wellness Pulmonary Rehabilitation Clinic in Fort Lauderdale, Florida. Additionally, Dr. Robinson is a board-certified pulmonologist and critical care medicine intensivist within the North Broward Hospital District. As you listen to the lecture, you can submit your questions for Dr. Robinson under the Engage tab. As a reminder, to receive credit for attending, please complete and submit the evaluation at the conclusion of this session.
Good afternoon. I'm Dr. Keith Robinson. I'm a pulmonologist and a critical care intensivist, and I'm happy to be back talking with everybody that's on the CME today about the pandemic lessons. Last year, about this time, I gave a talk talking about our experience through the first and second wave of COVID-19. And I shared at that moment the concerns related to oxygenation, and more importantly, I tried to share with everyone the pathophysiology of what we had learned in hopes of staving off more illness and, more importantly, to improve clinical conditions of our patients and our loved ones and family. And I think as we approach our 20th month, I can't believe it's been almost 2 years, we're starting to get a large amount of information back from how we performed in the first 12 months. But more importantly, we're getting data now as some parts of the world have been dealing and grappling with SARS-CoV-2 for almost exactly 2 years. Their experiences now are starting to reach the literature. And I'm hopeful to share a good number of insights that will not just change how we move into 2022, but I'm hopeful that the cost of the poor preparation that we've witnessed, and more importantly, the missed opportunities that we continue to see on a daily basis, even now, can hopefully make 2022 an easier year so that we all can return to some semblance of normalcy. You know, I like, as a pulmonologist, and my background is specific to physiology, I like trying to think about why certain things happen. Why is it that SARS-CoV-2 and more importantly, coronaviruses in general, why do they like living in bats? And why is it that the bat becomes such a huge part of why we get concerned about parts of the world where, say, wet markets or other means of food consumption and delivery become a huge issue? And it does, in many ways, involve where you live, the cleanliness of where you live. But I think specifically to the bat, I was really wondering why another mammal would be such a huge part of why with MERS or with the original SARS, we continue to see this animal come back and give us illnesses that cause great harm in the human species. And so what we learned from bats, and I think if it's not been well recognized, bats are small little rodents that fly. But in their size and the amount of energy that they have to expend, they really do have high levels of oxygen consumption that are super, I can call them human, but super normal for mammals. And so that 22 cc of oxygen per gram weight per hour, is a huge amount of oxygen consumption. That for a human being would be 125% of your max. Just to give you a sort of a ballpark, if you do exercise testing or if you're familiar with oxygen consumption. So just flying at 125% of your max in elevation, meaning just hovering, is a huge amount of energy. So adaptations, and I think Darwin has done some great things for bats in that their ability to generate such huge amounts of oxygen consumption were adaptatively beneficial for them. They have larger lung volumes. They have better diffusion capacity of oxygen. So for every molecule of oxygen they inhale, they're able to utilize a good amount of that oxygen just to keep themselves from becoming anaerobic to the point where they have to stop due to lactic acid buildup and fatigue. And I think some of the other adaptations that from a pulmonary standpoint and pulmonary vascular disease, if you recall from my experience, is also a huge part of my training, that they have larger right ventricles, which can generate a huge amount of flow through the lung. So not only do they have larger lungs, not only do they have a better ability to diffuse the oxygen through the lung, they have a greater ability to actually deliver blood from that heart and push it through the larger lungs that they have. So really efficient way to make sure that, again, they can stay aerobic in their activities and not anaerobic to the point where they have to stop, fall out of the air, and crash to the ground. So when you think about oxygen consumption, and I think that's where if you do exercise testing and you do exercise training, again, I'm not making exercise physiologists out of everyone, but I'm hopeful that you recall that you generate a huge amount of species called reactive oxygen species. So the breakdown material of metabolites that generate from metabolizing, say, carbohydrate, metabolizing fat, metabolizing glucose, generate these reactive oxygen species that are, unfortunately, for our species as mammals, they're pro-inflammatory and can really ramp up the amount of inflammatory cells that are drawn to working muscles. Just to give you kind of a caveat, we've recognized that in some runners, and I'm certain you probably remember Jim Fitz, the ultra marathoner in the 70s. Everyone was surprised when he had a bad outcome because he ran so much. They were concerned, how did a gentleman so fit have, unfortunately, a heart attack that caused him some harm? And what we learn is it's not just that you're fit, it's just if you overshoot, and so you can, believe it or not, have too much exercise, you can actually generate enough reactive oxygen species and enough tension and stress due to the blood pressure elevation associated with aerobic activity to cause inflammatory changes that can lead to and look a lot like atherosclerosis. And so I throw that pearl out there because that's generally where I'm headed with the rest of my talk in the next few slides, which is that the reactive oxygen species that we generate with just metabolizing oxygen leads towards, unfortunately, increased macrophage, increased inflammatory cells. And I think what we learned from bats specifically is they have developed a way to generate more interferon alpha. So interferon alpha for the bat specifically helps them to stave off the virus that unfortunately infects the species of bat that causes coronavirus illness in humans. And so they have a hair trigger release of this interferon in regards to when the virus actually infects them. And because they have generated so much reactive oxygen species from having to fly, they have countermeasures that are built in to help them fight the inflammation associated with coronavirus. And so by nature of their ability to fly and how much oxygen consumption they have to generate, they have naturally, I wouldn't call it natural, they have Darwinian ability to develop an anti-inflammatory response that unfortunately for humans causes us harm, but for the bat makes them a great species for the coronavirus to thrive. And unfortunately, if taken to the wet market or other locations in the world where these bats survive, then they have, unfortunately, risk of bleeding over into the human population if we have an intermediate host. So what's wrong with humans specifically is we don't have that adaptation. And I use this slide just to, again, illustrate what we know about SARS-CoV-2 and the patients that we've treated and that we've recognized to have horrible outcomes. I think last year in our talk, I had mentioned that high blood pressure, diabetes, age over 65, having prior heart disease, having family history of heart disease, all have one thing in common, which is atherosclerosis or hardening of the arteries. And the thing that atherosclerosis has is in common that again, that bats can combat that we cannot, is that they generate in patients with atherosclerosis a huge amount of oxidative stress. So I leave these disease entities here as an indication of of not just that, the heart gets affected, that the lungs get affected, but oxidative stress occurs throughout our bodies. It's not just organ specific, it's body and human specific concerns that lead towards the severity of illness that we can see in patients that are hospitalized with COVID-19. And so I think this becomes my great introduction towards what we now recognize as the way to manage the virus. My current work is in developing drug and investigational products to treat COVID. I've laid hands on, touched, and co-authored upwards 22, at this moment, probably 23 now, that I've sent one on an email, 23 studies just in COVID-19. And I think all the drugs that we're studying now work very specifically at mitigating the oxidative stress that unfortunately for some patients causes them to be critically ill. Again, just to summarize what we've been discussing, which is that if you've got modifiable risks, so you're a smoker, you're diabetic, you have high blood pressure, those are things that if you're not on therapy, or more importantly, you don't know you have those conditions, you're at greater risk of having concern. And I think that's what we found with the third and unfortunately the fourth wave of COVID, and more importantly in the unvaccinated, is that there's no such thing as a healthy human being. We all carry risk factors for something that's likely to be a risk for oxidative stress. And so even though, again, using GymFix as our example, even though you're going to the gym and you're quite active, you may have chronic inflammation associated with that activity that unfortunately increases your chance of having an outcome that relates and unfortunately causes hospitalization related to COVID. And so this just becomes a great way of understanding that what we're talking about is this virus really has a way to attack our inability to combat inflammation. And if you're chronically inflamed, you've already turned on the furnace essentially. And so all we really do is add more gas to that furnace by getting sick with SARS-CoV-2. And so a lot of the therapies that we're developing now are seeking to mitigate that inflammatory process related to how SARS-CoV-2 really ramps up, unfortunately, the chronic inflammation that we all generally have as baseline illnesses without recognition in some. So this macrophage that driven phenomenon is and this is just my example for everyone to understand what we're discussing, which is that atherosclerosis is a macrophage driven phenomenon. If it's not been explained in the literature or lay press, it is the macrophage that drives the illness and severity of illness with COVID-19. There are other white blood cells obviously involved because macrophages do a great job of recruitment. But I think the idea that for many, and if you live in the Western world, you're likely to have a diet that leads towards atherosclerotic plaque. And so if you have atherosclerotic plaque, whether you're diagnosed with hyperlipidemia or not, you're likely to have enough of these plaques where the macrophage is already turned on. And I think that's the sadness of the illness, is we don't generally do a good enough job of primary prevention with our subjects and our patients to understand who's really at risk for having bad outcomes a decade or so later. But I throw this out mostly just to remind that what we're talking about is a very specific but a highly damaging white blood cell called the macrophage that when it decides to turn on, it turns on everybody. And unfortunately for us, that leads towards a cytokine storm and more importantly, for some patients, severe COVID illness. And this is just my reminder for everyone from my talk last year, the things that we knew. We knew that this virus liked to attach, and more importantly, it needed to attach itself to the ACE2 receptor. And when it does so, it affects the renin-angiotensin system. Again, maybe an indication for why ACE inhibitors were protective, why ARBs were also protective in some patient populations with high blood pressure, but it also speaks to a mechanism of injury and more importantly, a mechanism from a therapeutic standpoint that might benefit. And so we do have some investigational products that look specifically at improving this estrogen. Believe it or not, it's an estrogen-driven phenomenon that protects the heart. So the pearl here being, there's a reason why women under the age of menopause don't have as many heart attacks as, say, men of the same age, and that's because they're protected by estrogen. And that estrogen actually works through this receptor, believe it or not. So the ACE in this setting can be protective if you have estrogen and not protective. And again, that borne out in a lot of things that we saw where men with COVID-19 did worse than women. So again, we've recognized these things. We're starting to put the physiology together, and it tells us everything about everything we knew prior to SARS-CoV-2, which is if you're a woman, you're going to be protected from anything that led towards this pathway being turned on. If you were a man, you were not going to do quite so well. And so with SARS-CoV-2, the acute remodeling that we see is really related to the angiotensin II activity related to, unfortunately, having ACE2 binding by the virus, which leads towards a more pro-inflammatory milieu that we all would unfortunately live in with increasing levels of angiotensin II. Angiotensin II now has also been earmarked as one of the markers that we can see in blood that leads towards patients who are at increased risk of having ARDS, or acute respiratory distress syndrome associated with SARS, but more importantly, patients who, in a very small percentage, who develop fibrosis associated with post-SARS illness after they've left the facilities and gone to nursing facilities to rehab. So this slide I used as an introductory slide a year ago, but it actually is quite solid in its ability to explain exactly what we know about the virus that has not changed. And I think the efficiency with which the virus continues to work is why I remind that everybody listening that we have 3 stages of illness. You have your acute viral stage. That's that stage most patients don't know they're infected the first 5 to 8 days. But as you can see, there's a huge amount of virus. And so if you're not ill or ill enough to worry about concerns, you could spread that virus to a large number of people. So we call that the R naught, so that the infectivity rate of a virus. And so in that stage 1, that's where therapies really need to be given, like monoclonal antibodies, things that can decrease the amount of viral load so that, again, you're hopeful not to fall into stage 2. And stage 2 is unfortunately the stage where most folks are sitting at home, getting sicker, having that silent hypoxemia that we've discussed prior and that you've seen in the lay press. And so you really fall into 2 camps with stage 2. You either stay stage 2A and go home, or you fall into stage 2B, where the inflammatory response due to the chronic inflammation associated with macrophage-driven phenomenon and all the oxidative stress that we were discussing causes you to get sick enough to unfortunately either go to the hospital, but more importantly, if you go to the hospital and not given appropriate therapy up front, and we'll discuss some of that in the next few slides as well, then the host inflammatory response takes over. And then that kicks you towards, unfortunately, the stage 3 or the hyperimmune or the cytokine storm stage of SARS-CoV-2. And in that stage, that's where generally we see a good amount of folks in the ICU, a good number of patients with ARDS, and the biomarkers that we all have come to recognize as being hyperinflammatory related to SARS-CoV-2. So when I talked about potential therapies last year, there was a lot of noise about what would benefit. And you see I've drawn a red line through all of those. Remdesivir, while it has some ability to mitigate the amount of virus and has some plausibility to affect, I'd say, a significant percentage of patients admitted to the hospital, because it's a hospital therapy, because it does have, unfortunately, increased risk of elevated liver enzymes, you really want to pick the population that's going to benefit the most. And so for me, that's patients in stage 2A. So if you're stage 2A hospitalized and you're hypoxic, you're likely still having enough virus where the remdesivir will give you some benefit. All the other therapies that I've listed here have crossed off because we've now almost close to 1,000 studies and all of these added together that demonstrate they just aren't effective. I've purposely tried not to intervene with the discussion of ivermectin, but I think it's important to mention just quickly that ivermectin is not an antiviral. You're probably aware of that. You know it's an antiparasitic medication. But I want to make sure that I've explained exactly what ivermectin is intended to do so that if there's any confusion about why it comes back into the literature and why it comes back in the press, is that what's forgotten about what ivermectin is that ivermectin increases interferon. It's that increased interferon response that allows for it to have the potential antiviral effect, but it doesn't actually kill the virus. And so what you're really hopeful for is that the ivermectin has enough white blood cells called T cells available that haven't been exhausted to generate more interferon so that you can protect yourself from further viral illness. The problem is by the time many patients are symptomatic, they're already at stage 2. And more importantly, they're likely already in the hospital seeking assistance, meaning that they've gone where the virus is probably not that prevalent. So you shouldn't expect a large degree of viral load decrease with ivermectin at stage 2. But more importantly, you probably already have enough inflammatory response on board to suggest that, again, increasing ivermectin dose or more importantly, increasing interferon levels will not benefit the patient. And we've learned that through study where we've looked specifically at interferons at stage 2 and at stage 3 and have found them not to be beneficial. In fact, latest paper a month or so ago demonstrated again that it had no effect whatsoever. So again, there's a Goldilocks effect to these therapies. If you can't affect the virus at the time you're exposed up front, then there are very few things currently on market that at least have gotten emergency use authorization that will benefit in the middle, and more importantly at stage 3, where folks are sick enough to be in the intensive care unit. And I think the therapies that we're currently studying really do have the ability to affect that reactive oxygen species. So I'll go into a little detail in the next slide, but I want to just remind again that if you can decrease the amount of viral load, which is now a well-recognized independent predictor of disease severity and mortality, decreasing the amount of virus keeps you out of the hospital. It keeps you from being on a ventilator, and hopefully keeps you from shedding enough virus to get more people sick and spreading and shedding the virus as they move through their daily life. So if you are able to get a therapy that can decrease the amount of viral load early, then the chances that that increased virus in your bloodstream, and more importantly in your airway and in your lung, has a lower ability to cause you more harm. And so I just list here the cytokines that are associated with having high viral load. And again, if you have a high viral load, your chances of having multi-organ dysfunction and ARDS or severe infection specifically really do go through the roof. The caveat to all of this is there is no FDA-approved quantitative ability in determining how much virus you have. And so even though I tell you viral load is what you need to know, I would view that if you have a positive viral test, do whatever you can to get that test directly treated with whatever therapy is available locally, whether again that's monoclonal antibodies or other, so that again you can decrease the chances that it continues to replicate and cause harm. It's just unfortunate we don't have a really good and rapid way to tell folks how much their viral load is, so that we can streamline the therapies and provide the correct Goldilocks therapy at the right moment at the right time. So in the advent of last year to this year, we had a new variant, and we're going to continue to see these variants. I don't want to scare, but I think the idea that this virus has a good length of time left before it's gone through every human being on this planet suggests, again, we're going to unfortunately have a longer period of time before we reach endemic levels. And that's from data internationally and maybe a little bit of internal data within my company. But the idea is that the variant that came through us this past summer really was, I think, an eye-opening experience for many who didn't understand how sick folks could get. Maybe they hadn't had an opportunity to see a patient or a loved one with it. But I think what it reminded is that if we can't mitigate the way that we spread the virus, then we should expect that folks who haven't protected themselves to become very sick and unfortunately increase the chances that they end up in the facilities and hospitals. And so, again, the unvaccinated were the greatest risk. Again, they had no level of protection. So therefore, no way to mitigate the viral load or decrease the chances that that viral replication was going to get high enough to cause them to be seriously ill. But I think, the idea that there might be other means coming down the road, hopefully will make that less of a concern going forward. And I'll leave it at least that comment at that point. But I want everybody to remember that this virus it's evolving. It's getting better. It's doing what most things that are alive on this planet try to do, which is survive. And so where it was closer to droplets in the alpha, it's a lot more like a puff of air now. So we call it aerosols. And so the fact that it can sit in really tiny amounts, and just the way you speak, the way you yawn, just normal breathing, and you can unfortunately exude a huge amount of virus in just those minimal amounts of breath coming from a patient or a friend or a loved one, means that, again, it's gotten better at how it's going to try and spread and survive. So I suspect that's likely to continue. The particles are really tiny now, believe it or not, but it's highly infectious. So even with a smaller amount compared to alpha, the Delta virus has a better way of attacking and unfortunately causing illness. So we know that there's a lot we don't recognize about Delta variant. We know there's a Delta plus coming from England. So the reason I'm really hopeful that everybody does what they can to protect themselves is that we don't know what other variants after Delta will be coming our direction. And as I said, it's getting more efficient, and more importantly, it's getting more transmissible. And then this is just kind of a reminder thought that after this summer, we were looking specifically at the difference between patients who had high viral loads in relations to those who had alpha variant versus Delta. And I won't belabor the point. I think the idea, again, that you're more than 2 times at risk of hospital admission with the Delta virus than the alpha variant. And again, a lot of that has to do with the changes in its aerosol capabilities, and more importantly, some folks were protected, some folks weren't. And so it was easier for us to determine, based on vaccination status in this data set, who was likely to be hospitalized. And so for my statisticians out there, I wanted to make sure I was clear that the wide confidence intervals that we do see in the slide makes the significance statistically questionable. But I would throw out there that the sample size that was studied, some avoidance of time bias, meaning when these samples were taken, and more importantly, there was some delay in reporting, which also may have affected the data collected. But I think the overall risk is there, which is that there is an increased risk and trend towards hospitalization if you get Delta versus the Alpha. And I don't recall seeing any more Alpha variants in the United States as of this week. So this is a curious slide that I wanted to start our next discussion with, which is that we recognize that if you went to a hospital early and you sought attention before you even knew you were hypoxic, you were going to do better because you were going to be that happy hypoxic patient who didn't know that their saturations were less than 92%. And so that's what this slide really highlights for me, which is we know that if you go to the hospital, your saturations are less than 94, you're likely to be hospitalized. So the goal of care at that point is to get you to an oxygen level that's going to be appropriate. And so what we have on this slide in this graph is the number of days it took for folks to stabilize, but more importantly, the difference between the survivors and non-survivors are highlighted because the patients who survived, they did so with, unfortunately, an increased number of days on oxygen therapy, which meant that their hypoxemia was significant. But more importantly, because of the need for hospitalization, they stayed longer in the facilities compared to non-survivors. So the caveat with the non-survivors are that they were older. Many of the folks in the non-survivors in this cohort decided that they did not want to go on a mechanical ventilator. Again, speaking to how severely ill these patients were that decided not to extend their life by mechanical means. And so that's why their length of stay in days is shorter. Their length of stay with oxygenation are lower. But for those patients who elected to go through with care, just short of needing at least an ICU stay, but were hospitalized, they did so at the peril of being in the facility for a good number of days. And I think that's the stressor that we all witnessed in the first two waves of the pandemic, which is how do we provide enough care to everyone, especially if everyone stays at least 10 to 12 days, which is what we found in this cohort. But we should expect that going forward, which is if you're sick enough to get hospitalized with COVID, expect to stay 10 to 12 days, not 2 to 3 as we ordinarily would expect with an upper respiratory infection. But you're going to be in a hospital for a bit of time, which means that bed levels are going to be a concern. And as we saw in South Florida, where I reside, we ran out of oxygen. We couldn't provide enough oxygen to everybody without having to squeeze and share. And so this is my reminder again that we've been here, done this. So let's now do it again in 2022. So let's talk about post-COVID syndrome, because I think we're now recognizing that folks that bounced into a hospital, stayed for an unfortunate 12 days on oxygen therapy, they got to go home at some point. And unfortunately, these are highly symptomatic folks, as you're probably aware. And then my next caveat would be that we know that there is no such thing as an asymptomatic COVID infection. So I wish that term would go away. If you got exposed to COVID and you got enough viral load, we could find some evidence, whether it was blood work, whether it was X-ray, or mild symptoms that you wouldn't have noted to be COVID illness itself. If you get exposed, you're going to have some level of concern that we're going to be able to find. And I think that's what we're recognizing now with the post-COVID syndrome is that for patients and subjects who did not have high symptoms, meaning mild symptoms, or would have considered themselves to be asymptomatic, are now having symptoms that they can't explain, concerns that they don't really recognize or can't really place, neurocognitive concerns, inability to remember things that they used to be able to remember. And so I think with that start, these are kind of the symptoms and signs that we recognize as being related to post-COVID syndrome. We really, believe it or not, don't have a good definition of what post-COVID syndrome is, aside from 60 days after being known to have been infected with COVID-19 and having symptoms that have persisted after resolution of illness. Then we consider that to be post-COVID. But there's no one lab value that I would pick out. Some folks with post-COVID have completely normal labs, some do not. I think a lot of that has to do, again, with severity of illness. If you ended up in the ICU, we could still see the abnormalities of that stay. But if you were asymptomatic or mild, it's really hard to put together your symptoms with blood work. And I think that's where some of the cardiopulmonary things that we've been doing now that the labs have all opened back. Hopefully they're all back open, and you're testing PFTs and CPETs again, that these symptoms can be tested, because I think objective information not only relays to the patient that you're understanding what's happening to them, but it also leads towards therapy. And I think that's why post-COVID syndrome will now become the, unfortunately, next new topic once we get into 2022. I think last year I had surmised and suggested that we were going to have a good amount of disability. And I think you saw that this summer, where post-COVID syndrome was added to the list of disabilities that can be considered for disability payment. I like this slide coming out of the UK because it reminds that we have to think large and not really get down into the minutia and trying to determine what we're looking for. And so we knew the virus had some effect on patients with diabetes. And we also found that it, unfortunately, for patients who had no known history of diabetes, they started to have inability to use their normal ability to lower their blood sugars. So if you were hyperglycemic in the hospital, you had a bad outcome. And I think more importantly, when we compare these folks to controls, healthy controls in this setting, or age-matched healthy controls in this setting, really can see that diabetes and the inability to control sugar was a huge part of not just what SARS-CoV-2 does. Remember, chronic inflammation is going to make your white blood cells behave fickle. And so there's going to be a stress that's created, and that stress will cause you to have to use more energy. And unfortunately for us, our body says sugar is the best energy you can use because you can break it down quick. And so I think that's what we see, is that SARS-CoV-2 not only increases the chance that you become clinically diabetic, but if you were pre-diabetic, again, I am a healthy person, I have no risk factors, but you never went to a doctor to note that you were pre-diabetic. I think that's a lot of what we're now witnessing and watching coming out of the international literature, which is that, again, there was no such thing as a real healthy Western diet and in person, even though, you exercise like crazy. Unless you see your physician quickly and more regular, you're less likely to recognize these concerns. So on the slide, MACE is major acute coronary events. They typically involve the prototypical heart attack, but most folks are in MACE also have arrhythmia, so atrial fibrillation, ventricular tachycardia, atrial tachycardias were common. We also saw a good number of folks with unexplained heart failure and myocarditis, and the myocarditis in this subset was not related to vaccination. It was, unfortunately, maybe they had direct viral illness and injury associated with SARS-CoV-2. And most are probably familiar, again, that chronic kidney disease is almost hand in hand with diabetes, and more importantly with MACE events. And so the cardiorenal syndromes were huge in the early presentation of SARS-CoV-2. And unfortunately, these were patients that we continue to see in our subset. But again, the things that I like about this data is that we now have patients who've gone home and are still having the same level of concerns as when they were in the hospital. So the incident rate, even though they're lower than the patients who were hospitalized, these new onset events were patients who went home, went back for their regular visits. And when they went back for the regular visits, they were found to have, again, increased rates of diabetes, increased rates of those MACE events. So the heart very much predominates in concerns that we are still following, and the kidney disease and liver disease that you see here on the slide. But I want to highlight the MACE events because, again, if you're working in cardiopulmonary labs, you're going to probably get a chance to see some of these post-COVID patients. And so you're going to have a large number of patients are coming to you with unusual chest tightness, shortness of breath, fatigue, exercise capacity concerns. So my reminder here is that the international standard, and I like saying international because that means everywhere in the world, everybody does the same thing. And unfortunately, in the United States, it's still catching up. But the international standard is that if you have a MACE event, you will have a cardiopulmonary exercise test. Without question, it's the first test that's done in most countries in the world in regards to how do you determine the significance of the MACE event, and more importantly, can you determine risk factors that might be modifiable in regards to management. So I highlight that for my next slide, which is that there's good abundance of data now coming out of Italy, out of France, good amount of data coming out of Brazil, believe it or not, related to exercise testing in patients with COVID. And so I place this up here because, patients who are fatigued and not able to do their continued activities, when they have CPETs done, they can fall into two camps: the deconditioned, or those that are now having what we now recognize as maybe a post-COVID POTS, or postural orthostatic tachycardic syndrome. I'll go through that in a second. the idea is I place this here early so that you understand that if you've got patients coming to your hospitals, to your labs, to your facilities, and more importantly, you've got some suggestions that they may have a MACE event associated with COVID. Very first thing I would ask the patient is, have you had a CT scan? Because again, you can still see some abnormalities that might be explanatory, excuse me. But more importantly, you want to make sure you've done something like a PFT, because again, that would be routine to determine why patients are short of breath. And here I highlight that the PFTs are generally normal in post-COVID. The one abnormality that we do see in some patients who are significantly affected is a mild to moderate decrease in their diffusion capacities, which do in some patients correct within 6 months after initial pulmonary function test. But the imaging, while it may be abnormal, it may be unremarkable, meaning nothing new has popped up on the imaging study. But I would continue to look to make sure, again, nothing new has popped up, like effusions, especially in the MACE population. But I think I highlight here in red the thing that we do recognize if you're doing CPETs, which is the O2 pulse. O2 pulse is your way of determining how much stroke volume, how much blood you're pumping out of the heart with each heartbeat. And what we see in our patients with post-COVID POTS is a decreased O2 pulse, where if you're deconditioned, your O2 pulse will be normal. It just may be flattened and not where it should be. But it gives you a good marker of who's got a surrogate for cardiac output or heart failure that might potentially require more intervention or more investigation. And the rest of these are just if you're a CPET person or an exercise physiologist, both have reduced peak VO2, so their actual consumptions are low. Again, that goes along with the poor exercise tolerance that we recognize, and maybe hospitalization if they were hospitalized. They do reach their anaerobic threshold. That's what the AT is. They reach it early in the deconditioned state, which is not too different from other deconditioning states that we see in CPETing. But I think the decreased anaerobic threshold in POTS is related more specifically to the O2 pulse. If you can't generate enough heart function and stroke volume to send blood through your working muscles and working heart, then your anaerobic threshold is not going to be where it needs to be, at least when compared to patients of the same age, weight, and height. So that decreased anaerobic threshold is something that I think will be prototypical. So I would highlight one last thing, because again, shortness of breath is such a prominent feature of post-COVID. What we recognize here is normal ventilation. So again, no suggestions in the patients with post-COVID or POTS that their lungs were badly damaged to the point where disability associated with the post-COVID syndrome is going to cause a decrease in ventilation. So CPETing becomes a great way of determining who's at risk of having other problems that might require investigation. So the dysautonomia or with the MACE, and this is just a quick cartoon just so that you understand a lot of the symptoms that I placed early are found within POTS. So dizziness, palpitations, fatigue, shortness of breath, chest discomfort, which is atypical, and maybe some treatments. Because again, if you're not able to have a CPET, you might want to try and at least give patients some suggestions of how they might get better. So that again, until you're able to do a formal cardiopulmonary exercise test, you're likely to be able to demonstrate that they improved by increasing fluid, avoiding long standing, and eating smaller meals, avoiding caffeine, believe it or not, is a huge one in POTS specifically. And what our gentleman here is demonstrating is that you get lightheaded when you stand up. So blood pressure is appropriate seated, but when you stand, blood pressure doesn't change. And I think that's at least one of the things that we look for when we're trying to determine whether patients have POTS. So orthostatic tachycardia for us is a huge one. You stand up, your heart rate goes above 30 beats per minute from baseline, but you're not orthostatic, meaning your blood pressure doesn't in and of itself change. It just stays the same, which also highlights this is not an orthostatic blood pressure issue, but a tachycardic syndrome, where your blood pressure stays where it should be, but because the pressure sensor, the chemoreceptors and the mechanoreceptors have not recognized the change in position, the sympathetic nervous system kicks in and attempts to keep your cardiac output appropriate so that you can stand upright and not fall forward. So if you're not able to do CPETing, these are the tests that we would ask you to do. So quantitative sweat, again, just making sure there's no risk factors for cystic fibrosis. And these others are just things that can be done in routine follow-up evaluation. So tilt table with electrophysiologist, real-time pulse wave. We've got really sensitive pulse oximeters that might be able to give you some variability in determining, again, whether the pulse wave suggests that there's increased sympathetic activity when standing. I'm not certain if everybody's ever heard of residual exertional dyspnea, but if you do CPETs, it is something that isn't differential for folks who are standing and short of breath. And residual exertional dyspnea has a lot of similarities to POTS syndrome, which is why I highlighted, because it is also in the narrower differential of patients post-COVID that might have continued concerns. And so what I highlight here is the difference between just routine residual exertional dyspnea versus POTS, which is that in most patients with POTS, you're going to be able to precipitate a history of a viral illness. So you want to ask that question specifically. Have you had a influenza recently? Have you had potentially COVID-19 recently? Because that history oftentimes will lead towards a therapy, and more importantly, a workup that leads towards a treatment. And this highlighted cartoon here shows that we actually now have potential treatment that treats POTS. Again, you have to diagnose it first, so I wouldn't recommend Avabradine without having a formal evaluation, either tilt table test or CPET. But I think the idea that somebody was looking at POTS prior to COVID-19, and this paper came out right at the beginnings of really trying to determine whether folks with COVID-19 had POTS, which is why I highlighted here, which is, medicine continued. We continue to study disease states, and common things being common, if your symptoms and signs look like a clinical entity that we've already been working on, and it more importantly has a therapy, you might have some benefit from the same therapy. But post-COVID, POTS is falling onto the radar of most pulmonologists now, which is why I highlighted here. And this is just, again, talking about residual exertional dyspnea and how it's similar to POTS. And I think the idea is that there's a dissociation between the neuromechanical ability for your body to understand and perceive what's happening in the periphery of the body and how it's perceived in the mind. And this becomes my segue into the neurocognitive concerns that we recognize, which is the dysautonomia that we see with COVID-19 affects not just your diabetic concerns and maybe your heart rhythm concerns related to sympathetic overdrive, but it may also lend its way towards the neurocognitive concerns that we recognize in post-COVID syndrome. So here are the differentials. So if you're looking up the differentials for what residual exertional dyspnea may be, these are typically the things that you'll find as a cause. So that, again, you can be highly specific with your patients at CPETing, exactly where their concerns are and how you can get them some therapy. So most folks with dyspnea on exertion, we should be able to tell them why. And there's no such thing in my world of not saying there's an answer for it unless you've truly looked. So this cartoon is hopefully just a reminder that when we talk about endothelial damage, some of the folks that unfortunately have post-COVID syndrome have neurocognitive issues. Again, the SARS-CoV-2 will bind to the ACE2 receptor, cause a hyperinflammatory, hypercoagulable state. Microthrombi, immunothrombus is a huge part of COVID. This is at the blood-brain barrier. Early on, we had a lot of postmortems that were demonstrating that there was some suggestion that the virus had attacked the blood-brain barrier, but obviously not many people are going to sit for a brain biopsy. So you have to wait for postmortems, and postmortems are difficult to really ascertain causation because it's really an afterthought, not a forethought in regards to what you see. And so, it doesn't lend itself to really telling you whether the mechanism of injury was directly related to SARS-CoV-2. But I think the idea is pretty solid that we can see evidence that the endothelium of the blood-brain barrier is inflamed or had been inflamed, and the microglia being more like macrophage in the blood-brain barrier, unfortunately, increases a well-known pathway. The kynurenine pathway is a well-known pathway related to stress. Most importantly, if you remember your Krebs cycle and your urea cycle, going back to biology, it plays a prominent role in tryptophan. And if you're an exercise physiologist, tryptophan is your one amino acid that leads towards your ability to dilate. And so again, vasodilation becomes a huge concern related to quinolinic acid and kynurenine production, which unfortunately leads towards the altered transmission of neuronal damage that we see in patients with, at least if we can MRI scan and see damage, we can see that they've lost some neuronal transmission ability by axons being unfortunately removed and pruned. And that leads towards the things that we see in our complaints, which is most folks will have attention deficits, cognitive deficits, some psychosis, and unfortunately, some folks are becoming depressed with this. So again, we can share with our patients that we're looking. We can share that there is a mechanism, and if you can determine a mechanism, there might be a therapy. And I think one of those therapies that we're now highlighting that you may have seen in the literature this week is that A serotonin reuptake inhibitor has been found in COVID-19 to have some benefit. So again, the neurotransmitters that we see with post-COVID syndrome are very clearly, unfortunately, depleted in patients with post-COVID. And so having a reuptake inhibitor, increasing the serotonin levels might augment your ability to stay on the good side of neurocognitive decline as opposed to the bad side. So hypoxemia plays a huge role. Again, if you're hospitalized with COVID and you end up in the facilities, you're likely to unfortunately have a increased injury to your cortical limbic system. That's unfortunately for us a system that's directly related to how we perceive shortness of breath. When I did my COPD lectures, it was generally the area that would light up like a Christmas tree. If you just gave the mere suggestion of walking up a flight of stairs, patients would highlight in their cortical limbic syndrome because it's an area that suggests, again, that dyspnea is a painful thought, meaning that walking up a flight of stairs is going to cause me to be short of breath, so I don't want to do it. So again, we see that with SARS-CoV-2 is unfortunately hypoxemia has injured this part of the brain system. And unfortunately, if your prefrontal cortices are damaged to the point where you're going to have an emotion associated with doing anything, you're less likely to want to get up and exercise or feel like you can. And again, from our COPD experience, the prefrontal cortices, when damaged in the cortical limbic, unfortunately, they don't want to do exercise. It's not that they can't, it's just they don't feel like they should because they're afraid they might hurt themselves. And I've already discussed the injury, so I'll move forward. But essentially, the several mechanisms that we see are related to damage to the blood-brain barrier, loss of neuronal transmission, and unfortunately, hypoxic injury and immune injury to the brain via the binding of ACE2 to the endothelial cells. So quickly, I'll go through long COVID. Long COVID is a significant concern. I don't know that I would call it long COVID. I like post-COVID syndrome. But I highlight here that we're going to see a good number of folks. If you've ever worked with patients in a skilled nursing facility that were in the intensive care unit, you know that they're fairly moribund. They don't have muscle mass. If they don't have muscle mass, they're less likely to be able to get back to the normal work that they were doing. And I think rather appropriately, COVID has been added to the Americans with Disabilities so that, again, we're not certain how you're going to make that determination of disability because it's a new illness. But I think if we use the standard tables that we would ordinarily use for disability, either by PFT, pulmonary function testing, or CPETing, you might be able to classify the severity. But I include this here because now post-COVID is a recognized disability. And as I suggested last year, we're likely to see a good number of patients with disability in the next year. So I'll run through the action concerns quickly because I think the idea that this time last year, I reminded that we ran out of oxygen. Texas told us very quickly with their very first huge wave in summer of 2020, they didn't have enough oxygen for all their patients that needed to go home. And I think at that moment, I warned that we were going to have the same thing occur. And so all the suppliers, all the durable medical equipment companies needed to prepare for that next opportunity because we knew at some point there would be another large enough wave where folks were going to require concern and more importantly, be able to go home with enough oxygen to keep themselves safe. And as I mentioned earlier, we had that issue happen here in Florida. We ran out of oxygen. And so a year later, almost to the day that I started compiling the slide deck last year, we ran out of oxygen and didn't have any means to send folks home. And so broadly explained, I think that, again, these issues indicate that we are at risk of running short in our supply chain, especially if the world is involved in a pandemic and that getting things from point A to point B will become more difficult. And so you want to have a streamlined way to make sure that this doesn't happen again, because I think in the first world, we shouldn't have large states like Florida, Georgia, Mississippi, North Carolina, South, name a southern state this past summer that ran out of something that was a commodity that was necessary to keep people alive. India was a great example of this. I think without talking about access to care, we saw that they needed over 200,000 oxygen concentrators just to meet the demand. Which was 5 times what they ordinarily would see in a normal year. And I think what we found is that if government doesn't work effectively, then you're not going to be able to meet the demands of what's occurring in an urgent or an emergent state. Now, India's federal government actually did levy, at least they were levying a good amount of the oxygen coming in, and they lifted that levy to allow for more import from outside of the country. So again, if your country's recognizing there's a problem, you're almost certainly going to have to be able to remove red tape and bureaucracy. And I think India learned that rather badly this past say, end of spring going into summer, which was that when we have things that are prohibitive up front, then you have to have a means to bypass that. And they didn't have a means early to bypass the levy that they placed onto items coming in from other countries, and that was prohibitive. And I think they unfortunately saw the loss of life associated with that until they were able to lift and remove those levies. And just another example here, the things that they learned, that we learned probably a year or so prior, which was that you want to do a root cause analysis. You certainly want to go down and assess the forecasted capabilities, not every quarter or until somebody calls to ask if you've looked, but a regular and a routine assessment of what's happening on the ground is necessary. I think once India was able to demonstrate that they could do so, they actually transitioned from industrial use of oxygen to more medical use. And again, the idea was to be able to protect their society and treat the patients that required oxygen therapy. And they made a very large discussion in regards to changing their industrial needs so that, again, that they were protecting the population. And here you see a concentrator. And I think that speaks to a larger concern that we're likely to have, as Africa is the next continent that's likely to have a unfortunate pandemic wave that we can't do very much about due to access concerns, which is electricity. So this patient fortunately was able to get a concentrator and a cord attached to some electricity. But what do we do when we aren't able to electrify the devices that require us to stay safe? So I'm going to end with a couple of slides. These slides are related to what we are doing, and this actually comes from California, who I think at this current stage is really proactive in how they're getting folks home. Because again, the idea that bed space may be limited is a key component to how we can keep the sicker folks safe. And I think the idea that we can send folks home in a safe manner, and I think LA County did a great job this past year in demonstrating that with adequate daily calls, being able to tell folks exactly what the concern should be, allowing them to self-manage. Self-management is a huge part of pulmonary rehabilitation. And I'm glad they took some of those concerns and applied it to COVID-19, but they provided them with the tools necessary in order to determine how sick they were. They called them frequently to make sure they were doing very well, or if they weren't doing very well, to come back to the facility. And what they found was they had a decreased all-cause mortality, a decreased all-cause 30-day readmissions. So they were able to keep people home. And more importantly, these were folks that were young. So again, these were patients that likely have some longevity and work productivity coming, and in order to keep them safe, they did what they could, and more importantly, they were able to save bed space. I didn't ask Stanford for permission, which is why I have their full document here. But I think the idea that, again, there are great ways to determine how to send folks home with oxygen, but how do you know when to stop? So I think Stanford's doing a very good job now of telling folks exactly, when you're improved, and more importantly, when it's time to stop oxygen therapy, because, in the world of pulmonary medicine, oxygen prescriptions can persist. And I think the idea that we need to return, refurbish, recycle these devices, and more importantly, get patients off of oxygen means that we have to have some streamlined and outlined way of making sure patients know when it's time to start or stop their oxygen therapy. So the pros of what I've been able to find is it supports a management goal, meaning that subjects are told exactly how much oxygen they can take in a day and not to go above a certain level, and reminded that it can be dangerous to receive too much oxygen. The cons are that it misses the opportunity to assess these patients at night. Again, oxygenation at night is the most dangerous part of the day for any patient. And so I think the idea that I would probably add a nocturnal study to determine, again, that the saturations are appropriate at night is missing in this paradigm. But I think, the overwhelming thing that's missed in this is that you can rewrite a prescription. Some patients may not require oxygen early and quick, which is great, but some patients may take a little bit longer in their recovery. And so the missed opportunity to rewrite the prescriptions, change the type of devices, maybe from a tanked delivery to a portable, might be missed in this opportunity to keep patients home, and more importantly, tell them how to wean themselves off of their oxygen therapy. So with that, I'm going to go through my concluding thoughts, a little puff of air to show you exactly what COVID looks like coming out of your nose and out of the mouth if you're breathing. Just a reminder that it's aerosolized, not droplets. So the take homes for me, viruses that are aerosolized, all upper respiratory infections, even the non-pandemic ones, create a huge amount of inflammatory response. I think the last pearl I'll share is that we recognize with influenza virus, the cytokine storm is dramatically higher, believe it or not, than those with COVID-19. I think we were just scared that the hypoxemia associated with COVID-19 created at least a nuanced difference between the two viruses. But we're recognizing now, and I think that's why we're a little calmer in our approach to folks with COVID-19, is that the inflammatory response can be found with most upper respiratory infections. I'm hopeful that, again, we don't reinvent the wheel. We operationalize medicine in hopes of keeping people alive during a pandemic or during a disaster. And I'm hopeful that what we've learned over the past 20 months no longer puts us in a place where we don't have enough oxygen anywhere in the world, but more importantly, that we don't run the risk that we unfortunately cause more harm than benefit by not protecting ourselves in the future. And my last two pearls are really for my pulmonologists and respiratory therapists, which is, we got to get back to using our cardiopulmonary services. I mean, I think for COVID right now, it's the forefront of diagnosis and management, especially in regards to POTS. And I think that the pandemic has truly highlighted the need to educate. I think the education is woeful, but I think if we can globally educate everybody about the use of oxygen, how it's prescribed, and more importantly, what the benefits of oxygen therapy are, then we're likely to have an outcome going forward, even with patients after the pandemic that require oxygen, where they're familiar with it. And I think that's the familiarity that's missing in the 51-year-old population that LA County found, was that they never thought they would be on oxygen until they were in their maybe 80s or 90s. And so if we can have a larger discussion with folks about what oxygen is intended to do, I suspect we're going to have less fear about folks going home with it. So with that, I'm happy that I've had an opportunity to talk with you all about what we've learned, and I welcome your questions.
It's been another incredible day of education, hearing from some of the best minds in the nation in sleep and respiratory disease management. Hopefully, you've been completing the evaluations for each lecture you attended. For each course evaluation you completed, you will see that course reflected on your certificate of attendance. To locate your certificate, click on the account link in the left-hand vertical navigation. Scroll to the bottom of the screen, and under Attendance Certificate, click Request New Certificate to download a certificate detailing all the CEUs you have earned. Also, your feedback regarding today's event is very important to us. Look for a survey in your email in the next few days. This education forum is for you, so let us know how we can make it even better for next year. And one final thank you to our speakers, sponsors, and DME partners, and an extra shout out to the MSc Planning Committee, co-led by Julie Banyas and Jen Woking. We hope to see everyone again next year. That's a wrap.